at least as a primary lesion. So I have no conflict of interest. This is a lesion that first described by Kernohan about 100 years ago. The incidence is quite low with a male predominance, but it's almost the most often a tumor of this region. The usual age of presentation is from third to fifth decade, and it's clinically characterized by 6 to 24-month history of low back pain. So it has a quite long history of symptoms that many times they're not considered right. So the average duration, according to this paper, it's from 13 months to 8 years, which is a quite long period because they are slow growing. It derives from the filum terminale, and it consists of 13% of all the ependymomas of the CNS. They mainly situated in the lumbar spine, just below the medullary conus, but may also spread to thoracic spine and sacrum, and this comes as a secondary lesion. They may metastasize along the neural axis, and the gold standard treatment is surgical tumor gross total resection, which is not very easy most of the times. The impact of adjuvant radiotherapy remains currently debated. This is the outline of the lesion. So I wanted to give you the outline of the lesion regarding all the aspects. It's very important that according to the new WHO classification, it jumped from grade 1 to grade 2. And this is because of the, this reflects the higher propensity for recurrence and the CSF dissemination, even though it's a slow growing nature. So until 2021, this was a grade 1 tumor, but nowadays it's a grade 2 tumor. This is a series of hours. You see it's about 25 years long. So it's about 15 patients, 11 males and 4 females, with age ranging from 16 to 55 years. The average duration of symptoms before diagnosis was more than 2 years, so it's quite long. And the follow-up is, fortunately for some people, reaches the 18 years, but the median post-op follow-up is about 5 years. So you can see the clinical features. All of the patients had pain. About 2/3 of them, they have the motor deficits. About 40% of them, they had sphincter dysfunctions, and the sensory loss had about 15%. Regarding MRI features, I would say that MRI is very sensitive, but moderately specific in detecting anatomical contact between conus and Cauda Equina tumors. So you can see that the mass may be isotense or slightly hypotense on T1. This is the most of the cases. It can be isotense to CSF on T2 sequence. This is also most of our cases. And enhancement after administration of gadolinium is in about all of our cases. So it's, I mean, most of the cases, in most of the cases, we can achieve a preoperative diagnosis. Treatment in our series was the gross total removal in most of the cases, subtotal removal in about 30%, and only partial removal in 2 cases. In 12 of these cases, especially those after 2001, a multimodal intraoperative monitoring or just an intraoperative monitoring was advocated. And this was very, very helpful, as you will see in the next slides. Adjuvant radiotherapy was advocated to all patients with subtotal or partial resection, although this is not very established in the literature. There are 3 patients with complications, 2 patients with urinary dysfunction that was not there before, 1 patient with weakness at urinary dysfunction, and 1 patient with aseptic meningitis. So keep in mind that this is a tumor that aseptic meningitis can occur if there is a spread of the capsule of the tumor. We tried to in a way to see what was the outcome related to the initial presentation of the tumor. So we could see that the outcome was excellent in patients with pain only, and when the sphincter dysfunction was the case, the outcome was not so good, which is actually we waited for that, but also we saw that. And we tried to correlate the lesions, the extent of surgical resections to involvement of the neural elements, especially conus medullaris, and with tumor encapsulation. Preoperative MRI showed that the lesion affected the conus in 40% of our cases, which was significantly associated with intraoperative findings. This information could actually guide us in preoperative planning and also give the right advice to patients to treatment options and to what to wait after the operation. Just trying to find in the literature if there is a classification. We found this classification regarding the location, the exact location of the lesion. This is a classification that tried to do in people from America. I mean, Kenan Arnautovic from the States with his colleagues from Serbia, and actually they advocated this 5-type classification based on tumor location and its correlation with the extent of the resection. They saw that extramedullary, intramedullary lesions incorporating filum terminale represent the type 1A, which can be actually the best case because gross total resection can be achievable. You can see that there are other cases like type 1B with extramedullary conus with lumbar nerve root and filum also invasion. Type 2 with intramedullary conus and filum terminale. Type 3 where the upper lumbar cord enlargement has been evident. Type 4A with the lower part of spinal cord and medullary conus. And there is also a cystic component. And type 4B with the entire medullary conus and cystic compartment, signs of hydromelia or syringomelia in the cord or the upper part are evident. Type 5A, where there is tumor outside the lumbar cord, and B, outside the vertebral canal. Apparently, the four last categories cannot be cured by surgery. Let me just address the key role of multimodal intraoperative monitoring, which is an essential adjunctive surgical tool for deciding and planning maximal safe tumor resection. We have to say that the intention is the maximal safe tumor resection, which means that we stop when there is an affection of a neurological function that was not affected before. So keep in mind that we proceed until we are sure that there is no neurological lesion after our operation. So there is the triggered electromyogram method, which is a rather newer method, where after minimizing current interference with a cotton patty, the TEMG is performed using a bipolar neurostimulator to recognize the rootlets. After I used this method, I have to admit that I was not so aggressive as I was before. Sometimes that rootlets, at least in this case, that you will see afterwards, the rootlets, if the rootlets don't show anything, we can go on, but otherwise we have to be very, very, very careful. Sorry. I think this is the... Now you can see a case. I will try to... Now you see that we open the dura with a classical way. And of course, surgery is a treatment of choice, as we said. All surgical procedures were performed under general anesthesia using a posterior approach to the spine. Intraoperative monitor, as I said, was used at the discretion of the surgeons, of course. And after induction of anesthesia, the patient was flipped in the prone position, and the rostrocaudal extent of the surgical incision was planned by localizing the spinal levels with fluoroscopy. Dorsal midline incision was made at the appropriate spinal level, and the midline dissection was carried down to the spine process and the lamina. And then typically following a subperiosteal dissection, the thecal sac was exposed after either a laminectomy or laminoplasty, according to the surgeon's preference. Ultrasonography can be done sometimes to detect where the tumor is, exactly the tumor is. You can see this tumor is dissected from the roots of the Cauda Equina, and here is its adhesion to the filum terminale. all this work is performed with the intraoperative monitoring. Usually there is a vein, there is a vessel, a vein on the filum terminale. If it's possible, we try to preserve the filum terminale. Most of the times it's not possible. And as you can see, there is, we try to take out the tumor in one piece. We try not to open the capsule, because opening of the capsule many times means shedding of the tumor. And here you can see the rootlets, some rootlets. And finally is the last piece, which is dissected from the rootlets. I'm sorry. And this comes out at the end. So following discharge, the typical initial post-op follow-up is scheduled for 6 weeks after the surgery, where the MRI is performed. And patients with known residual tumor were referred to the medical oncology or radiation oncology departments for consideration or adjuvant treatments. We try to detect some risk factors from the literature. And it's very interesting in this paper, which actually looked at the SER analysis. This is a database of all the cancers in the States. They considered about 800 cases. They saw that the incidence, of course, is higher in males and the Caucasians, as we said in the beginning. And what they see, that the receipt of adjuvant radiotherapy is a negative prognostic factor, although adjuvant radiotherapy is strongly recommended, especially for younger patients. And of course, surgery was with the goal of gross total removal remains the primary treatment modality. In another very interesting paper, they found that of course, total removal, if it's possible, is a good treatment. And but gross total removal appears to offer no advantages compared with subtotal removal with radiation therapy for conus lesions, where preservation of involved nerve roots may be important. This comes to stick to what we said before, that our goal is the safe resection. The largest, the gross total removal, but with safe, in a safe mode. Another observation was that although patients may be worse during the initial post-op phase, they often recover. And patients with a good neurological status at presentation have the best chance for a good neurological outcome. This is what we saw in our series as well. And another series of 28 cases emphasize the significance of tumor size and location in predicting tumor resectability. And although the patients did have a significant worsening again in their neurogrades post-op, there were no deaths or cases of paraplegia in the long play. And last but not least, this also a large series of 72 patients, which actually found that complete surgical resection under the premise of protecting neurological function is an important factor. Adjuvant radiotherapy is recommended when the tumor invades the capsule. And given the prevalence of drop metastasis, they strongly recommended that MRI of the whole craniospinal axis should be performed before surgery to observe distant metastasis. So, some messages to take. There are rare tumors with a relatively good prognosis. They have a very prolonged duration of symptoms. There must be a high index of suspicion, especially in younger patients with recurrent episodes of low back pain or radicular pain, but even with just low back pain. I still remember a guy from when I was in the UK who was a student in Oxford who kept going to the ER for more than 2 years. I mean, he was suffering from low back pain, and they just gave him some painkillers, and he had this kind of lesion. Early evaluation of Cauda Equina syndrome is avoiding long-term neurological complications. Surgery is treatment of choice, and if this can be done, gross total removal is a treatment of choice. And I would say that nowadays the monitoring, intraoperative monitoring, is an essential adjunctive surgical tool for deciding on the planning for a maximal safe tumor resection. So, thank you for your patience.